Hello everyone, this is Dr. Jashwin, General Surgeon. Today we are going to see about Fmge recent paper, June 2026 surgery recall. So the first question we are going to see is, according to ATLS burn resuscitation protocol, an adult weighing 50 kg has 20% total body surface area, second degree burns. What is the fluid required for the first 24 hours? So here they are given according to ATLS formula. Already we know one more formula, that is Parkland's formula. According to Parkland's formula, the amount of fluid that is required for first 24 hours is 4 into body weight of the patient into percentage of bones, that is total surface area of bones, total body surface area that is involved by bones. Okay, this is the Parkland's formula. But this Parkland formula, it has led to hyperolemia, it has led to volume overload. So it has been replaced by ATLS formula. So ATLS formula for first 24 hours, the formula is 2 into body weight into total body surface area. So here the weight of the patient is 50 kg and the total body surface area that is involved is 20. So 2 into 50, that is 100, 100 into 20, that is 2000 ml. So if they have asked particularly Parkland's formula, the fluid that is required for the first 24 hours, then it would have been 4 into 50 into 20, that is equal to 4000. If they asked according to Parkland's formula what is the fluid that is required for the first 8 hours, then we have to divide it into 2. So first 8 hours it would be 2000 ml. Another for the next 16 hours it would have been another 2000 ml. This is according to the Parkland's formula. Here they have given second degree burns. So what else we have to know? Okay, what else we have to know? What is first degree burns? First degree burns, it involves the epidermis alone. Epidermis alone. Second degree burns, we have two second degree burns. Okay, superficial as well as deep. Okay, superficial, it involves epidermis and part of dermis. Up to papillary dermis, it is involved in superficial burns. In deep second degree burns, epidermis and the total dermis is involved. In third degree burns, subcutaneous tissue is involved. In fourth degree burns, apart from deeper to subcutaneous tissue, muscle, everything is involved in fourth degree burns. Okay, this is the degree of burns. How is this percentage calculated? So percentage is calculated according to rule of 9. Okay, rule of 9, it gives a approximate percentage of burns. So what is this rule of 9? Rule of 9, in case of adults, it involves, it gives rule of 9. So 9% is given for the entire face, front and back of the face, 9% is given. Then for the anterior chest, we have given 9%. For the anterior abdomen, another 9%. Then upper part of the back, another 9%. And lower part of the back, another 9%. Then for the upper limb, 9%. Each upper limb 9%. For the lower limb, each lower limb 18%. 18% for each lower limb and 1% for perineum. So as a whole 100%. Okay, 9% for the head. Okay, head for the chest 9 and back 9. For the abdomen, anterior abdomen 9. For the posterior abdomen 9. For upper limb, each upper limb 9. For lower limb, anterior part of lower limb is 9 and posterior part of lower limb is 9. For each 18%. Remaining there will be 1% that is given for the perineum. Okay, so this gives the approximate percentage of burns. This is Valle's rule of 9. Then the next question is, a patient is diagnosed with esophageal perforation, presented after 1 day. Post-contrast leak was confirmed. What is the next best management? Okay, next best step in management. So here there is an esophageal perforation, but the patient has presented to us after 1 day. Okay, it is a late presentation. Late presentation, we can't manage it using conservative management. We have to manage it using surgical management. Apart from that, in radiological investigation, there is a post-contrast leak. So that also we can't manage conservatively. So the answer for this is early surgical exploration. If the patient has present to us within 12 to 24 hours, and if there is only a minor leak and there is no sepsis, then we could have managed it conservatively using fluids and the mari nasogastric tube and the mari pote, we would have managed the patient conservatively. But here the patient is present to us after 1 day. Also there is leak noted in the radiological diagnosis, so we have to go for early surgical exploration. So what is the most common cause for this esophageal perforation? The most common cause is iatrogenic. So if we are using the endoscope for any diagnostic or therapeutic purposes, most commonly therapeutic purposes, for removing some foreign body, if we are using this endoscope, that is the most common cause for esophageal perforation. That involves the upper one third of esophagus. Okay, apart from that, another what other causes for esophageal perforation is barotrauma, that is Borhave syndrome. So here the patient coughs with a closed glottis. So there with the closed glottis, if the patient is coughing or if he is vomiting, then it would have caused a complete tear of the esophagus. Okay, complete tear of esophagus involving the lower one third of esophagus. Where it most commonly involves is left posterolateral region. There is complete tear of esophagus. Patient is vomiting against a closed glottis. Okay, closed glottis, that gives a complete tear. This is seen in Borhave syndrome. Suppose if there is a partial tear, then it is Mallory-Weiss syndrome. Mallory-Weiss syndrome, that tear, it will be seen in the gastroesophageal junction. Okay, but this Borhave syndrome, it is most commonly seen in the lower one third left posterolateral region, and it involves a complete tear of the esophagus. What is this? One triad is there for this Borhave syndrome, that is Mackler's triad. Okay, Mackler's triad, it involves chest pain, retching or vomiting, subcutaneous emphysema. If the question was like this, patient presents with vomiting, if there is a retching is there, chest pain is there, after an episode of alcoholic patient, after an episode of forceful vomiting, he is presenting to us with subcutaneous emphysema, adukaprom vandu chest pain, retching or vomiting, then you have to suspect a Borhave syndrome. Okay, next, a 66-year-old man presented with sudden onset severe pain in the left lower limb for 5 hours. On examination, limb is cold and pale. Distal pulses are absent. Sensory loss is present over the toes. And motor power is 4/5 at the angle. There is no fixed mottling or muscle rigidity. What is the preferred treatment? Here we can see there is 5 P's. Okay, what are the 5 P's? Pain. Okay, we can see pain is there, pallor is there, pulselessness is there, then paresthesia is there, along with that paralysis is there. Complete paralysis is not there, but motor weakness is there. These 5 P's are suggestive of what? It is suggestive of acute limb ischemia or acute arterial occlusion. It is most commonly due to an emboli. Okay, 5 hours தான் present பண்ணியிருக்காங்க. So that emboli, the thrombus, it had been travel from somewhere else and it would have lodged there in the vessel, and it is causing this acute limb ischemia. So 5 P's are there. Patient is presenting with pain, pallor is there, pulselessness is there, paresthesia is there, but there is no paralysis, but mild weakness is there. Power, it is 4/5. So according to Rutherford's classification, there is 1, 2 and 3. According to Rutherford's classification, here there is sensory loss of the toes, motor deficit, there is mild motor deficit, that is 4/5, mild motor deficit, but patient is not paralyzed. Patient has present earlier. Okay, 5 hours later patient has presented. So how are we going to manage? We are going to revascularize. Immediately we are going to revascularize the patient. Okay, so if such a patient present to us, immediately first step what we are going to do is we are going to give heparin. Okay, heparin மட்டும் கொடுத்தா பத்தாது, then we have to revascularize the patient. Either we can do an embolectomy. Okay, embolectomy is preferred. Embolectomy using a Fogarty's balloon. Okay, with the help of a Fogarty's balloon we are passing after the Fogarty's balloon மூலமா we are passing the balloon after the, if the thrombus is here or embolus is here, it is passed across this, and after that the balloon is dilated and it is brought back. Okay, so the embolus is removed with the help of Fogarty's balloon. That is embolectomy. Okay, embolectomy that is preferred in this condition. Revascularization is done using embolectomy. Suppose adu panna mudiyala or in mild cases we can go for catheter directed thrombolysis with thrombolysis can be done. Okay, but it has its own complications and contraindications. Okay, in this case there is no paralysis. If the patient is presenting with paralysis or the patient has been presenting late, okay, inga vandu 5 hours la present pannitaanga, late ah present pannitaanga, if the patient is having any paralysis, then we have to go for amputation. We can't save the patient. Okay, patient save பண்ணி இருக்க முடியாது. We can't save the limb of the patient. We have to go for amputation. So the correct answer here is we have to do a urgent revascularization. Okay, so we have done revascularization, so perfusion is improved, but patient can go for one complication. Okay, immediate perfusion வந்து reperfuse பண்ணிட்டோம் அப்படின்னா blood will flow very fast to there and it can cause the swelling of the muscles and patient can go for compartment syndrome. In that case we have to go for fasciectomy. So revascularize பண்ணும்போது patient can go for reperfusion syndrome, patient can go for compartment syndrome போகும்போது we have to do a fasciectomy. Next, a patient involved in a road traffic accident has a GCS of E4, B3 and M4. Respiratory rate is 28 per minute. Blood pressure is 90/60. What is the appropriate triage category? Here patient is having a road traffic accident. We are going to triage this patient. Usually triage is done for any mass casualty. Suppose இது ஒரு mass casualty வச்சுக்கலாம். In there we are seeing a patient that but the patient oda GCS is less. Okay, 4 plus 3 7 plus 4 11/15. Okay, respiratory rate is high and blood pressure is low. Patient is having shock, patient is unstable. So according to triage category they are asking what will we tag this patient. Okay, so triage la what all colors we know red color, yellow color, green color and black color. How are you going to remember this order? This order is similar to that of a traffic signal. Traffic signal மேல என்ன இருக்கும்? Red color, yellow color, green color. It will be covered in black color and the black we are going to put it in the last. So red is immediate. If we have to manage the patient immediately, then we are going to tag the patient with red. Yellow is urgent and green is not urgent. Okay, non-urgent patient is tagged with green. Black is patient is moribund or unsalvageable. We can't save this patient or the patient is dead, then we are going to tag the patient as black. Okay, here the vitals are unstable, patient is having a head injury, maybe ulla vandu there can be any hemorrhage. So immediately we have to manage this patient, immediately we have to do something for this patient. So here the answer will be red. Okay, so first priority, red is given the first priority. Immediately we are going to manage this patient. So what all conditions? Any tension pneumothorax, chest injury, tension pneumothorax, if there is any profuse bleeding, அதுக்கப்புறம் hemothorax is there, flyal chest, some chest injuries எல்லாம் தெரியும்ல, அதில் ஏதாவது இமீடியட்டாக நீடில் தொரக்கோசென்டோசிஸ் ஆர் ஐசிடி பண்ணணும். that cases we are going to tag it as red in color. அதுக்கப்புறம் any intra-abdominal bleed if we are suspecting, then we have to operate the patient immediately. In that patients we are going to tag them as red in color. Apart from that, any extradural hemorrhage we have to put a burr hole in that patient. So Immediately, if you put the burr hole only, patient won't go for secondary brain injury. In that cases, we are going to tag the patient as red in color. In this case, patient may be suspected epidural hemorrhage da, extradural hemorrhage da. So we are going to tag the patient as red in color. If second priority is given for any compound fracture, degloving injury, ruptured abdominal viscus, pelvic fracture, spinal injuries. These patients are இவங்களும் சிக்காக தான் இருப்பாங்க, பட் தே கேன் வெயிட் ஃபார் சம் 1 hour அந்த மாதிரி தே கேன் வெயிட் அண்ட் தே கேன் பி மேனேஜ் லேட்டர். ஸோ சம் போத் போன் ஃப்ராக்சர், if the question was like both bone fracture with profuse bleeding, what will you choose? Profuse bleeding. And if he is unstable, we are going to go for red தான். ஓகே, பேஷண்ட்க்கு வந்து ப்ளீடிங் இருக்கு, அன்ஸ்டேபிளாக இருக்காங்க, then we have to go for red in color. Then third priority is given for green color. Here, if there is any simple fracture, sprain, if there is some laceration, then it is coded as yellow, green color. If the patient is not breathing, patient is dead, if the patient is having severe head injury, if there is 100% burns, அதுக்கப்புறம் வந்து if there is evisceration of bowel, complete bowel, எல்லா பவுலுமே வெளியே வந்துச்சு, chest is opened, அந்த மாதிரி கண்டிஷனில் whatever we do, we are not going to save the patient. So they are given the last priority. They are tagged as black in color. Okay, black color. Here GCS is given as E4, V3, M4. So what does this E4, V3 and M4 stand for? That we are going to see. So GCS, total score of GCS is 15. Okay, as 15. What is the minimum score of GCS? Minimum is 3. But in case of an intubated patient, it will be 2T. We are going to see about that. Okay, so we have 3 components, E, V and M. So EVM machine வச்சு ஞாபகம் வச்சுக்கலாம். E for eye opening, V for verbal response and M for motor response. Increasing order it is going to go. E, the maximum response is 4. V, the maximum response is 5 and M, the maximum response is 6. So here E is 4. E4 na enna, patient is spontaneously he is opening his eyes. Like us, he is spontaneously opening his eyes. If it is E3, then if we are telling the patient to open the eyes, if the patient opens the eyes to speech, please open the eyes. If you are telling the patient kanna thorainga appdi சொல்லும்போது, if the patient is opening the eyes, then it is E3. If you are giving some pain stimuli கொடுக்கும்போது, if the patient is opening the eyes, then it is E2. E1, if there is no response, then it is E1. Okay, then V5. V5, if the patient is oriented to time, place and person, then it is V5. If the patient is confused, then it is V4. If the patient is speaking some inappropriate words, okay, inappropriate words, sentence form பண்ணாத inappropriate words if he is speaking, then it is V3. V2 is incomprehensible sounds, some different sounds if he is putting, then it is V2. If there is no response at all, then it is V1. Okay, next M வந்து M6 இருக்கு. நார்மலா if it is moving his limbs, then it is M6. M5, if the patient is localizing the pain. Okay, localizing the pain, இந்த இடத்துல pain இருக்கு, if you are giving some pain there, if the patient brings his hand towards there, if he is localizing the pain response, then it is M5. Then M4, if we are giving some pain response, if he is giving some withdrawal reflex, okay, withdrawal reflex, then it is M4. Then there is M3, if there is abnormal flexion, patient is in the abnormal flexion of the upper limb as well as lower limb, then it is M3. Then there is M2, if the patient is in abnormal extension, okay, extension, if the upper limb is extended and lower limb is also extended, then it is M2. Sorry, M3 la வந்து there will be upper limb flexion and lower limb extension. In M2, upper limb will be in extension and lower limb also will be in extension. M1, there will be no response at all. So here patient is E4. E4 na he is spontaneously opening his eyes. V3 na enna artham, he is talking some inappropriate words. Okay, M4 na enna artham, he is withdrawing to pain. So இந்த மாதிரி பேஷண்ட்க்கு then the GCS is 11/15. Then there is minor head injury, mild head injury, moderate head injury, severe head injury. If the patient's GCS is less than or equal to 8, then we are going to tag the patient as severe head injury. We have to intubate this patient. Even if the vitals are stable, we are going to intubate this patient. If the GCS is 9 to 13, then we are going to tag them as moderate head injury, moderate head injury. Okay, if the GCS is 14 or 15, but the patient is having LOC, if the patient had a history of LOC, then it is a mild head injury. If the patient GCS is 14 or 15, there is no LOC, then it is a minor head injury. Like this, we are going to classify the head injury. In this patient, the GCS is 11, so patient is having a moderate head injury. Extradural hemorrhage, there will be lucid interval. Patients, there will be LOC immediately after the trauma. After that, there will be a transient phase of consciousness. After that, patient will go for unconsciousness. This is lucid interval. It is most commonly seen in extradural hemorrhage. Next, a 42-year-old woman undergoes bariatric surgery for morbid obesity. That is understood. For morbid obesity, we are going to do bariatric surgery. Which of the following procedure is associated with greater risk of fat-soluble vitamins? Okay. In the options, there are 4 options. Sleeve gastrectomy is done, adjustable gastric banding, intragastric balloon, biliopancreatic diversion. There are 2 types of bariatric surgery. One is malabsorptive surgery. That is, we are going to cut the bowel. Bowel on this, certain segments of bowels are removed so that the absorption won't happen and patient weight will get reduced. Another type is restrictive type. We are going to restrict the stomach. Okay, stomach we are going to cut the stomach so that stomach transit time will be fast. In that type of bariatric surgery is there. Here, sleeve gastrectomy is a type of restrictive type. Okay, adhe marida adjustable gastric banding, also intragastric balloon. All the 3 are restrictive type of bariatric surgery. Whereas biliopancreatic diversion or biliopancreatic diversion with duodenal switch, these are mostly, they are malabsorptive. Okay, they are malabsorptive as well as they are minimally restrictive. Malabsorption there will be malabsorption of vitamins. Okay, malabsorption of vitamins, ileum some problems irundhuchna, ileum is responsible for bile salt absorption, that is responsible for fat soluble vitamins metabolism. Here, if the patient has done some malabsorptive surgery, they will be having this fat soluble vitamin deficiency. So in the options we are going to rule out the restrictive type. Okay, option A, B and D are restrictive type, whereas option C is a malabsorptive type. Okay, mostly malabsorptive type. So that's the option. So yenga we will be having this fat soluble vitamin deficiency, that is biliopancreatic diversion. Biliopancreatic diversion with duodenal switch. Also, they can also be seen in Roux and Y gastric bypass. Okay, Roux and Y GJ will be done, gastric bypass will be done. In that, there will be equal malabsorption, equal restrictive type. Okay, in the moonlime there will be fat soluble vitamins malabsorption. Which irrigation fluid is preferred during bipolar TURP? Okay, bipolar TURP what fluid is preferred? Okay, what is TURP? Where it is done? TURP is done for benign prostatic hyperplasia. Adula transurethral resection of prostate. Because of the enlargement of prostate, patient will be having benign prostatic hyperplasia. So we are going to insert a resectoscope through the penis and we are going to resect the prostate. Okay, resect பண்ணும்போது segments will be coming out. So we have to continuously irrigate பண்ணிக்கிட்டே இருக்கணும். Okay, so for the irrigation we have to give some fluid. Irrigation fluids are given. Okay, in olden days, irrigation fluid that was given was hypertonic. Okay, hypertonic fluid was given. Okay, hypertonic fluid, but it has led to hyponatremia. It has led to dilutional hyponatremia. It has led to TURP syndrome. Okay, there will be decreased sodium levels and patient will go for CNS manifestations. So it was replaced with isotonic solution. Isotonic solution, that is 1.5% glycine. If the question was which is the best irrigation fluid for TURP, then it is 1.5% isotonic glycine. But the question was which irrigation fluid is preferred during bipolar TURP. Okay, so this 1.5% glycine, that is a isotonic solution, whereas hypertonic solution எல்லாத்துக்குமே what cautery will be used is we can use monopolar cautery. Monopolar cautery can be done, but for normal saline monopolar cautery cannot be used. Okay, it will conduction வந்து ஒழுங்கா இருக்காது. So bipolar cautery it is used for normal saline. Okay, normal saline la வந்து bipolar cautery is used. In case of any longer surgeries bipolar cautery is used. அங்க வந்து what fluid is used is normal saline. So which irrigation fluid is preferred during a bipolar TURP is that is normal saline. Whereas what is the best fluid that is given for TURP procedure is that is isotonic glycine, that is 1.5% glycine. Yeah, hypertonic solution la kudukkradilla because it has led to TURP syndrome or dilution hyponatremia. A 35-year-old woman undergoes surgery for thyroid nodule. Post-operatively, she develops ptosis and meiosis on the operated side. Okay, there was ptosis irukku, meiosis irukku. Ptosis, meiosis, anhidrosis, inophthalmus, loss of ciliary reflex, இது எல்லாமே it is suggestive of Horner syndrome. Horner syndrome, why does this Horner syndrome come? Because of the damage to the cervical sympathetic chain. Okay, so recently there was minimally invasive video assisted thyroid surgery was carried out. Okay, minimally invasive. Okay, இங்க வந்து இவ்வளவு பெரிய இன்சிஷன் போடுறது பதிலா minimally invasive they will be going through some poem மாதிரி some they will be going to the transoral route, அப்புறம் retroauricular route, அதுக்கப்புறம் வந்து transaxillary route. Okay, transaxillary endoscopic thyroidectomy is done. But while going through this they are going very blindly. Okay, இங்க தான் we will be having cervical sympathetic chain, இங்க வந்து we have to go to the thyroid. So while going through that route they are more prone for damaging the cervical sympathetic chain. So this transaxillary endoscopic thyroidectomy is more prone for Horner syndrome. Okay va, inga nama normal total thyroidectomy la Horner syndrome oda chances are very 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 less. Okay, we will be having hemorrhage, we will be having nerve damages, most commonly external laryngeal nerve oda damage, we will be having hypocalcemia, we will be having hemorrhage, அதெல்லாம் இருக்கும். பட் Horner syndrome ஓட chances are very very less in case of a normal thyroidectomy. Whereas இது transoral vestibular thyroidectomy எந்த ரூட் வழியா போறோம், இந்த ரூட் வழியா போறோம், we are not going to cross this at all. So there is no chances of Horner syndrome with transoral vestibular thyroidectomy. Lateral cervical lymph node biopsy. Okay, இங்க தான் எடுக்க போறோம், அங்க நம்ம பார்த்து தான் எடுக்க போறோம், சூப்பர்ஃபிஷியலா தான் எடுக்க போறோம். We are not going to damage the cervical sympathetic chain. So most likely associated is transaxillary endoscopic thyroidectomy. They are asking about they are asked about the recent advances. Okay, a 30-year-old man is brought to the emergency department after a stab injury to the left lower chest. Blood pressure is 60/59. அதாவது patient is unstable. Chest X-ray is normal. What is the next best step? What are we suspecting in this patient? There is a stab injury to the left lower chest. Left lower chest la என்ன இருக்கு? Lower chest la along the 9, 10 and 11 ribs la enna irukku, spleen is there under this ribs. Okay, lower chest la injury irukku, we are suspecting a splenic injury. Okay, a splenic injury, patient is unstable. Among the given option unstable irukanga, we can't go for CT, we can't simply leave the patient for observation, we have to go for E-fast. Okay, E-fast போயிட்டு if there is any fluid collection then we are going to proceed with surgery. Stab injury, if the patient is having some stab injury la if the patient is unstable or if there is peritonitis, if the bowel has eviscerated outside or if the peritoneum is breached, immediately we are going to go for surgery. We are not going to wait for any E-fast, any CT, we are going to go for surgery. இங்க அந்த ஆப்ஷன் இல்ல, there is no option of surgery. Among the option, the best option is E-fast. Okay, among the best option is E-fast. What is this E-fast? Extended focused assessment sonogram of trauma. Okay, so what are the regions that are screened with the help of this EFAST? Previously there was FAST. அது என்ன பண்ணுச்சு? Right hypochondrium, left hypochondrium, this epigastric region, then suprapubic region. Okay, heart பார்த்தோம், liver பார்த்தோம், spleen பார்த்தோம், bowel ஏதாவது leak இருக்கா, ஏதாவது fluid collection இருக்கா, suprapubic region ஏதாவது fluid collection இருக்கான்னு பார்த்தோம். Now it is extended to the thoracic cavity. We can see the anterior thoracic cavity, left anterior thoracic cavity, right anterior thoracic cavity. We can see if there is any pneumothorax, hemothorax எதா இருக்கா, epigastric region பார்க்கறது வச்சு we can see any pericardial tamponade எதா இருக்கா. These things can be screened with the help of a EFAST. So ஒரு blunt injury abdomen patient வராங்க. If the patient is having a blunt injury abdomen, if the patient's vital is stable, we can go for initial investigation is EFAST. We can go for CCT abdomen. We can find where there is bleed and then we can go for surgery. If the patient is unstable, initial investigation of choice, everything is EFAST. Now recently they are having CT console எல்லாமே next to the casualty இருக்கு. So immediately they can do CT according to books. Investigation of choice in a unstable patient is EFAST in a blunt injury abdomen. A 32-year-old professional singer undergoes thyroidectomy. After surgery, she is unable to sing high-pitched notes. High-pitched notes she is unable to sing, but her speech is normal, which nerve is most commonly involved. After thyroidectomy or total thyroidectomy, the most common nerve that is involved is not recurrent laryngeal nerve, it is external laryngeal nerve. Okay, external laryngeal nerve followed by recurrent laryngeal nerve. ஏன்னா we'll be பார்த்து will be seeing recurrent laryngeal nerve damage பண்ணக்கூடாதுன்னு சொல்லிட்டு, but we'll be carelessly damaging the external laryngeal nerve most commonly. This external laryngeal nerve patients voice will be normal but high pitch sound வந்து வராது. So here the answer is external branch of superior laryngeal nerve, whereas in recurrent laryngeal nerve their voice will be normal. If there is bilateral recurrent laryngeal nerve palsy, patient can go for stridor. Okay, during laparoscopic cholecystectomy, a Veris needle is inserted through the umbilicus. After insufflating a small amount of CO2, insufflation pressure rises abruptly. Okay, pressure அது பாட்டுக்கு ரைஸ் ஆயிட்டே போகுது. The crepitus is felt around the umbilical port. What is the most likely cause? Where is this Veris needle used? Veris needle is used in laparoscopic surgery in order to create a pneumoperitoneum. Okay, for closed technique. இதில் closed technique ஏதோ இன்சிஷனும் போடாமல் first we are going to insert the Veris needle. This image is the Veris needle. We are going to insert the Veris needle. We are going to enter into the peritoneal cavity. அங்கே pneumoperitoneum create பண்ணுறோம் with the help of CO2. Then we are going to put the other ports. Okay, இந்த port வழியாவே we are going to insert another cannula. அதை வச்சுக்கிட்டே we are going to put the other ports. This is the open closed method. Open method we will be using the Hassen's cannula. Okay, Hassen's cannula it is used in open method. Open method we are using the Hassen's cannula. Here closed method la we are putting this Veris needle. Veris needle உள்ள போடுறோம். ஆனா என்ன ஆகுது, pressure அது பாட்டுக்கு increase ஆகுது, but the patient he or she is having crepitus around the umbilical cavity. So what has happened is, this is the abdominal wall, this is the peritoneal cavity, here we are having the bowel. Okay, this is the abdominal wall. So we would have accidentally inserted the another Veris needle in the subcutaneous plane. So tappana plane la we have inserted. So pressure it is going on increased. So ulla gas irukanaala while palpating the anterior abdominal wall we are having the crepitus. So the answer is Veris needle it is entered into the subcutaneous space. So proper insert பண்ணல அப்படினா we will be having these symptoms. Next, a 25-year-old man undergoes elective splenectomy. Okay, splenectomy it is done for hemolytic condition, hereditary spherocytosis, idiopathic thrombocytopenic purpura. Emergency splenectomy it is done for trauma. While ligating the splenic vessels, the surgeon preserves an artery to maintain the blood supply of stomach. Which artery is it? Okay, among the option எந்த artery வந்து if a surgeon will be preserving, surgeon will be preserving the left gastroepiploic artery or left gastroomendal artery. Okay, இதுதான் it is a branch of splenic artery. Okay, it is a branch of splenic artery, this left gastroepiphytic artery. In the image la paathale theriyudu, it supplies a large area of stomach oda the greater curvature la large area it is supplying. It is coming from where? It is coming from the splenic artery da. It's a branch of splenic artery. Okay, main splenic branches la podu from splenic artery. Short gastric artery also supplies the stomach. Ana compared to short gastric artery, this left gastroepiphytic artery supplies major portion of stomach, so it has to be preserved while doing a splenectomy. Where does this splenic artery comes from? It comes from celiac axis. Okay, so celiac axis, it has three branches. One branch is left gastric artery, another branch is proper hepatic artery. From there we have the gastroduodenal artery as well as common hepatic artery. Another branch is the splenic artery. It supplies the pancreas. Pancreas is supply பண்ணுது. It can also give the left gastroepiphytic artery as well as short gastric artery is also a branch of this. But this left gastroepiphytic artery, it supplies major chunk of stomach. That's why we are going to preserve this left gastroepiphytic artery. What are the grades of spleen? Okay, spleen we have 5 grades. Okay, 5 grades according to CT classification. We can have 5 grades. Okay, 5 grades. In that 1 and 2 it can be managed conservatively. 4 and 5 we have to go for surgery da. Surgery போறோம். Spleen preserve பண்ண முடிஞ்சதுனா we can go for splenography. We can suture the spleen. Or spleen preserve பண்ண முடியல, in 5 ல வந்து there will be shattered spleen. Spleen will be separated from the blood vessels. ஒண்ணு பண்ண முடியாது. We are going to do splenectomy. Okay, in case of grade 3, if the patient is stable, we are going to manage them like 1 and 2. If the patient is unstable, we are going to manage them like 4 and 5. Okay, that is a management of grades of management of splenic injury. Okay, splenectomy பண்ணதுக்கு அப்புறம் in case of an emergency splenectomy, we are going to give the patient with 3 vaccines. Okay, the spleen is responsible for the phagocytosis of capsulated organism. என்னென்ன organism? Haemophilus influenza, meningococcus, then pneumococcus. Okay, pneumococcus. இந்த மூணு பாக்டீரியாவோட phagocytosis is spleen is responsible for the phagocytosis. Now we have removed the spleen. அப்போ phagocytosis of these 3 capsulated organism does not happen. So we are going to give vaccination. Haemophilus influenza, meningococcus, pneumococcus. Vaccination is given post splenectomy. If we are going to do an elective procedure, we are going to give this before the surgery itself. A 20-year-old man presents with intermittent mucoid discharge from a small opening along the anterior border of lower 1/3 of sternocleidomastoid muscle since childhood. What is the most likely diagnosis? Okay, thyroglossal fistula, where does it come? It is a midline swelling. Thyroglossal cyst, it is a midline swelling. அதுலேருந்து வரக்கூடியது தான் thyroglossal fistula. It is a midline swelling. Here they have given, it is seen in the sternocleidomastoid. It is a lateral swelling. Okay, lateral swelling or lateral sinus, lateral opening. What is this thyroglossal cyst? Thyroglossal cyst எங்கேருந்து வருது? It comes from thyroglossal tract. Where does this thyroglossal tract it starts from? It starts from the foramen cecum. Where does this foramen cecum occur? Foramen cecum is seen in the anterior 2/3 and posterior 1/3 of tongue. அதில் தான் foramen cecum இருக்கு. From the foramen cecum there is a tract called thyroglossal tract. It comes down and it gives 2 lobes. Okay, 2 lobes கொடுக்குது. From that lobes தான் எது வருது? Thyroid is coming. This occurs in the gestational age group. Okay, அப்போ this is happening after coming down and after giving 2 thyroid lobes. This thyroglossal tract, it has to obliterate, similar to that of a processus vaginalis in case of hernia. Okay, testis கீழே கொண்டு வந்ததுக்கு அப்புறம் that has to obliterate. அதே மாதிரி this thyroglossal tract, it has to obliterate. If it does not obliterate, it can form, அதுலேருந்து வரக்கூடிய cyst is called thyroglossal cyst. Okay, thyroglossal cyst. So what is the most common site of this thyroglossal cyst? It is subhyoid or below the hyoid region. Okay, so what surgery is done for this thyroglossal cyst? Cyst trunk operation. We are going to remove the entire tract. We are going to remove the entire cyst. Also a part of hyoid is removed, that is cistern operation. Suppose இங்க ஒரு சிஸ்ட் இருக்கு, ஒரு swelling இருக்கு, ஒரு சிஸ்ட் இருக்குன்னா சிஸ்ட் இருக்குன்னு சொல்லிட்டு ஐஎன்டி பண்ணிட்டோம் அப்படின்னா that can form a thyroglossal fistula. That is an acquired condition that is seen in the midline. Another one point about this thyroglossal cyst is they move with swallowing deglutition, they move along they move also while a protrusion of tongue also it moves, because it starts from the foramen cecum. Foramen cecum enga irukku? It is present in the posterior 1/3 of tongue. Okay, so thyroglossal fistula is not the answer. Okay, then what is this branchial fistula? Branchial fistula the answer. What is this branchial fistula na? It is due to the persistent second branchial cleft. Okay, second branchial cleft. Where it is present is, it is present in the lower 1/3 of the neck near the anterior border of sternocleidomastoid. We are having the sternocleidomastoid laterally. Adula lower 1/3 la, if there is a opening, we have to suspect a branchial fistula. It can be either acquired or congenital ஆவும் இருக்கலாம். It comes from the persistent second branchial cleft. If there is a swelling in the junction of anterior 1/3 and middle 1/3 of the anterior border of sternocleidomastoid, that is a branchial cyst. Okay, branchial cyst is seen in the junction of anterior 1/3 and middle 1/3, upper 1/3 and middle 1/3 rendume it's a remnant of second branchial cleft da. But branchial cyst it comes, இது ஸ்டெர்னோக்ளிடோமாஸ்டாய்ட்னா அப்பர் 1/3 க்கும் மிடில் 1/3 க்கும் நடுவுல வருது. பட் branchial fistula it comes in the lower 1/3. One difference இருக்கா? Branchial cyst it is lined by squamous epithelium. Branchial fistula it is lined by ciliated columnar epithelium. This question can be asked in future examination. Okay, so இந்த இமேஜ்ல இருக்க மாதிரி தான் நமக்கு क्वेश्चन கேட்டிருக்காங்க. Lower 1/3 of the neckல along the anterior border of sternocleidomastoid there is a mucoid discharge. Okay, mucoid discharge it is suggestive of branchial fistula. Okay, branchial fistula. If the patient is having a lateral swelling, how can we prove that it is a cystic hygroma? Okay, a cystic hygroma na it is brilliantly transluminant. If the patient ku vandu question la if they have given us option a lateral swelling but it is brilliantly transluminant, we have to go for the answer of cystic hygroma. Only a little bit of swellings are brilliantly transluminant. One cystic hygroma, number 2 hydrocele, number 3 epididymal cyst, number 4 it is meningocele. Okay, number 5 ranula. Okay, ranula. These 5 swellings are brilliantly transluminant. If lateral border of neck la, if the swelling is there and if it is brilliantly transluminant, we have to go for cystic hygroma. Next, a 52-year-old man presented with the slowly enlarging painless swelling in the right parotid region. FNAC confirms it is a malignant parotid tumor. The surgeon wants to assess the first group of lymph nodes involved in metastasis. Okay, so option la pathona first option submental irukku, second option deep cervical lymph nodes, third option is preauricular and superficial parotid lymph nodes, fourth option is submandibular. So from the parotid first enga pohum, it goes to the preauricular and superficial parotid lymph nodes. From there it goes to the deep cervical lymph nodes. So the answer is first node it is the preauricular and superficial parotid lymph nodes. Okay, so what is the first group of lymph node that is involved in this parotid tumor? Preauricular and superficial parotid lymph nodes. A 55-year-old woman, okay, presents with recurrent renal stones, number 1, bone pain, number 2, muscle weakness, fatigue and depression. What is this suggestive of? This suggestive of some hypoparathyroidism, some parathyroid problem. Okay, ஏன்னா depression இருக்கு, muscle weakness, fatigue is there, renal colic is there. Apart from that, patient is also having hypercalcemia. Okay, எல்லாமே it is suggestive of primary hypoparathyroidism. Also in the question la they have given patient is having elevated PTH. Okay, parathyroid is elevated. Also phosphate level is less. எல்லாமே it is suggestive of primary hypothyroidism. The most common cause for primary hypothyroidism is parathyroid adenoma followed by hyperplasia. Okay, so parathyroid adenoma followed by hyperplasia. This parathyroid adenoma, it is associated with MEN1 syndrome. Pituitary adenoma இருக்கும், parathyroid adenoma, pancreatic tumors, all are associated with MEN1. Then MEN2A layum will be having parathyroid adenoma. Then MEN4 is also associated with parathyroid adenoma. MEN3 la mattum da parathyroid adenoma, sorry, MEN2B la mattum da parathyroid adenoma varadu. So most common cause for primary hypoparathyroidism is parathyroid adenoma followed by parathyroid hyperplasia. Okay, so suppose or parathyroid adenoma irukku, we have to localize, we are suspecting a parathyroid tumor, we have to localize. Enna scan use பண்ணுவோம் அப்படினா Fmge scan. So question la Fmge scan ன்னு வந்துச்சு அப்படினா we have to think that it is related to parathyroid தவிர வேற எங்கேயுமே this Fmge scan is not going to come. Fmge scan is used for localization of parathyroid. Okay, so we have diagnosed it as parathyroid adenoma. We are going to remove the adenoma alone. Okay, மைனரா போயிட்டு அந்த parathyroid மட்டும் எடுத்துட்டு வர போறோம். In that condition parathyroid கரெக்ட்டா எடுத்துட்டோம், diagnosis is correct that it is parathyroid adenoma and not other parathyroid is not involved, and if there is no parathyroid hyperplasia, how are we going to confirm? We are going to confirm with the criteria called as Miami's criteria. Okay, Miami's criteria. So what does that state? So we are going there, we are going to remove the parathyroid adenoma suspected, and the parathyroid adenoma oda parathyroid gland is removed. Okay, what we are going to do is we are going to preoperatively calculate the or measure the parathyroid hormone level. Okay, parathyroid hormone level is measured preoperatively. Now we are going to remove this parathyroid. Okay, in the particular parathyroid adenoma is removed, and after 10 minutes we are going to repeat the parathyroid hormone. Okay, parathyroid hormone order levels. If there is more than 50% decline in the parathyroid hormone levels, then we have removed the single parathyroid adenoma remove பண்ணிட்டோம். இல்ல அப்படின்னா there is some other problem, there is some other extra adenoma இருக்கு, extra some other parathyroid tumor is there, we have to suspect, because the half life of parathyroid hormone is 7 minutes. நம்ம we have waited for 10 minutes. 10 minutes wait பண்ணதுக்கு அப்புறம் என்னாச்சு, there is more than 50% decline. அப்படினா என்ன அர்த்தம், half life தாண்டிச்சு. அப்ப parathyroid எந்த parathyroid பிரச்சனை இருக்கோ அதை நம்ம தூக்கிட்டோம்னு அர்த்தம். So that is Miami's criteria. A 28-year-old man is brought to casualty with history of trauma. He had sudden breathlessness, absent breath sounds on the right side. Okay, history of trauma irukku, there is a patient is having sudden breathlessness, also breath sounds are absent in the right side. Chest x-ray shows a large right sided pneumothorax with complete lung collapse. Patient is hemodynamically stable. Okay, hemodynamically stable, JVP எதுவும் elevate ஆகுதுன்னு கொடுக்கல. So we have to suspect that it is not a tension pneumothorax. Okay, it is a large simple pneumothorax. Okay, a simple pneumothorax. Tension pneumothorax na they would have given patient won't be normal. Okay, he won't be stable, patient will be unstable. One they would have given us elevated JVP, raised JVP will be given. So in this condition patient is having a simple large pneumothorax, ana large pneumothorax, so we have to do some intervention. So next best management, அடுத்த best management என்ன அப்படின்னா we are going to go for a intercostal tube drainage. Okay, ICD drainage பண்ண போறோம். We are not going to do a emergency thoracotomy. Emergency thoracotomy, where what are the indications for this emergency thoracotomy? Emergency thoracotomy is after inserting a ICD. If we are suspected a hemothorax, we are inserted an ICD. ICD insert பண்ண உடனே if there is more than 1 to 1.5 liters of blood collection, போட்ட உடனே இவ்வளவு blood வந்துச்சு அப்படினா என்ன அர்த்தம், there is some major bleed inside. So we have to go for thoracotomy, anterolateral thoracotomy பண்ண போறோம். Okay, number 1. Number 2 is for 3 consecutive hours. Okay, more than 200 ml per hour வந்து blood வந்துகிட்டே இருக்கு அப்படினால என்ன அர்த்தம், there is some active bleed inside.
அப்போ உள்ளே போய் அதை போய் சூச்சர் பண்ணாலோ அதை போய் லைகேட் பண்ணால் மட்டும்தான் அது சரியாகும். ஸோ இந்த மாதிரி more than 200 ml per இது இருந்துச்சுன்னா we are going to go for emergency thoracotomy. ஓகே, thoracotomy-யோட இண்டிகேஷன். நம்பர் 3, if there is some அயோட்டால ஏதாவது ஒரு இன்ஜுரி இருக்கலாம். ஓகே, நம்பர் 3. நம்பர் 4, ஈசோஃபேகஸ் ஏதாவது ரப்சர் ஆயிருந்தா we are going to go for thoracotomy. நம்பர் 4. இதெல்லாம் தான் இண்டிகேஷன்ஸ் ஃபார் எமர்ஜென்சி thoracotomy. ஓகே, a 33-year-old woman presents with a 2-month history of spontaneous unilateral blood-stained discharge from a single duct. Every point is important. Okay, there is no palpable breast lump. What is the most likely diagnosis தான் கேட்குறாங்க. ஓகே, எது வரும்னு கேட்கல, இந்த ஆப்ஷனில் இருக்க நாலுமே வரலாம். ஓகே, they have asked the most likely diagnosis. இந்த fibroadenoma வராது. ஓகே, fibroadenoma there is no breast discharge, but breast discharge can be seen in duct ectasia, can be seen in carcinoma, can be seen in duct papilloma. Bloody discharge can be seen in duct ectasia, can be seen in carcinoma, can be seen in duct papilloma. They have asked for the most likely diagnosis. Okay, most likely diagnosis they have given the single duct. Okay, single ductல வந்து most common discharge வருது, அதுவும் bloody discharge வருதுன்னா it is duct papilloma. Okay, duct papilloma usually involves a single duct. Single ductல if there is a bloody discharge, most common cause is duct papilloma. Single duct if there is a serous discharge, most common causes duct papilloma. Okay, plus they have given there is no palpable breast lump, so we are going to rule out this carcinoma also. Okay, duct ectasia வந்து single duct involve பண்ணும், multiple duct involve பண்ணும். Duct ectasia ஓட common discharges paste like toothpaste like discharge அல்லது muddy discharge, brown discharge, இந்த மாதிரி colorful greeny discharge, இந்த மாதிரி colorful discharge இருக்கு. Okay, in fibroadenoma there will be no discharges. Okay, this tabular column it is very important. So discharge from a single duct, if it is blood stain, it can be intraductal papilloma, intraductal carcinoma or duct ectasia. மூணு ஆப்ஷனும் இருந்துச்சு, ஆனால் first most common is intraductal papilloma. If it is a serous discharge, அப்பவும் most common cause is duct papilloma followed by duct hyperplasia, duct ectasia, ductal carcinoma. If the discharge is involved more than one duct, அப்போ duct papilloma rule out பண்ணிக்கலாம். Duct papilloma it involves single duct, single duct, single duct. Okay, more than one duct. If it is blood stain, most common causes carcinoma. அதை தாண்டி தான் duct ectasia. Duct ectasiaல என்ன வேணா வரலாம், single duct involve பண்ணலாம், multiple duct involve பண்ணலாம், என்ன type of dischargeனாலும் வரலாம். If it is black, green or muddy or paste like discharge from multiple ducts, it is duct ectasia. If there is a purulent discharge, then it is periductal mastitis. Mastitis இருந்துச்சுன்னா there will be first discharge. Lactation, milk discharge எப்போ வரும், நார்மல் பிரெக்னன்சியில் வரலாம், அடுத்து கேலக்டோரியாவில் வரலாம், pituitary tumor hypothyroidism it can come. Okay, a 32-year-old man presents with a stab injury to the neck above the clavicle. Pulse rate is high 120. Blood pressure is 90/70. Patient is unstable. Patient is having a stab injury to the neck. What is the next step? If the patient is unstable, எந்த லெவலில் நெக்கில் இன்ஜுரி இருந்தாலும் we are going to go for immediate surgical exploration. There are 3 levels in the neck. Okay, 3 levels in the leg for injury. Okay, from thoracic inlet to the cricoid cartilage, it is level 1. From the cricoid cartilage to the angle of mandible, it is level 2. From the angle of mandible to the base of skull, it is level 3. Okay, level 1 வந்து very dangerous. Level 2 தான் most common involve பண்ணும், most common surgically accessible ஏரியாவும் இந்த level 2 தான். இந்த இதில் above the clavicle கொடுத்துருக்காங்க, எந்த லெவல்னு கிளியராக கொடுக்கல, பட் patient is unstable, we are going to go for surgery. அதை தாண்டி if there is a stab injury to the neck, what other indications are necessary for going for a surgery அப்படின்னா, if the patient is presenting with a stridor. Okay, stridor இங்கே hematoma இருக்கு, if it is going on increasing. Number 2, அந்த woundலேருந்து பப்ளிங் வருது, அப்படின்னா என்ன அர்த்தம், there is connection with the thoracic cavity. ஓகே, அப்போ அதனால தான் உள்ள இருக்க ஏர் வெளியே வருது. if there is bubbling, if there is hoarseness of voice, ஏதாவது ஒரு nerve injury, நிறைய வைட்டல் ஸ்ட்ரக்சர்ஸ் ஆர் ஹியர். ஓகே, ஸோ இந்த மாதிரி ஏதாவது ஒரு வைட்டல் ஸ்ட்ரக்சர்ஸை இன்ஜூர் பண்ணி அதோட காம்ப்ளிகேஷனோட ப்ரெசென்ட் பண்ணுறாங்க அப்படின்னா we have to go for immediate surgical interventions. A 28-year-old man meets with a road traffic accident. He is hemodynamically stable but complains of right flank pain. Okay, examinationல right flankல there is some abrasion. CCT is done and it shows a grade 3 kidney injury. What is the next best management? Okay, so for the kidney injury, if it is grade 1, 2 or 3, we can go for conservative management. Okay, அதே இது grade 4 and 5, we have to go for surgical management. அதுவும் particularly grade 5, we have to go for nephrectomy. Okay, nephrectomy ஏன்னா there will be shattered kidney similar to that of எங்க ஸ்ப்ளீன்லேயும் grade 5 is shattered spleen. Okay, இங்கே அதே மாதிரி grade 5 is shattered kidney. It will be completely devascularized from the vessels. அப்போ no use of keeping the kidney. So we are going to do a nephrectomy. Whereas in grade 4, there will be urine leak. So கொஸ்டினில் ஏதாவது யூரின் லீக் இருக்குது, யூரின் எக்ஸ்ட்ராவைசேஷன் இருக்குது, அதுக்கப்புறம் மேஜர் வெசல்ஸ், இது மேஜர் அரீனல் ஆர்ட்ரி வெயினில் வந்து கட்டு இருக்குது, ஆனால் ஷேட்டர்ட் கிட்னி மாதிரி கொடுக்கல, அவல்சன் மாதிரி கொடுக்கல அப்படின்னா we have to go for grade 4. grade 4ல் வந்து if the patient is ஸ்டெரைலாக இருக்காங்கன்னா டிஜே ஸ்டென்ட் பண்ணலாம், இல்லை அப்படின்னா அது வழியாக பிக்டெயில் ட்ரைனேஜ் பண்ணி அந்த யூரினை வந்து we can extravasate. Okay, so in this patient is stable. Okay, patient ஸ்டேபிளாக தான் இருக்காங்க, grade 3 liver injury. So we can go for conservative management. Okay, மானிட்டர் பண்ணிட்டே இருக்கலாம், ஏதாவது பிரச்சனை இருந்துச்சுன்னா we can go for further surgery. அங்கே பார்த்தோம்ல ஸ்ப்ளீன்லேயும் grade 3ல if the patient is unstable, we have to go for surgery தான். If the patient is stable, we can wait. So this is the grading for spleen. Okay, spleen already பார்த்துட்டோம். Okay, spleen. Next, a 28-year-old man, stab injury to the neck. The wound is located between the cricoid cartilage and angle of mouth. We have already seen. என்னது cricoid cartilageக்கும் angle of mouthக்கும் நடுவில் இருக்கு. அப்போ என்ன zone கேட்டிருக்காங்க? We have already discussed this. That is zone 2. There is only 3 zones. Zone 4 இல்ல, 3 zones. Okay, zone 1 வந்து thoracic inlet up to the cricoid cartilage. If it is present from the cricoid cartilage up to the angle of mouth, it is grade 2. If it is present above the angle of mouth up to the base of skull, it is zone 3. Okay, so that completes this part 1 of discussion. We will be having the next part very soon. Thank you.